Hi, everyone, and welcome to a live chat with Nurse Linda. Today's topic is overlooked body functions. Linda Schultz is a leader and provider of rehabilitation nursing for over 30 years and a friend of the Christopher and Dana Reeve Foundation for close to 2 decades. Now I'm going to turn it over to Nurse Linda. Hi, Linda.
Hi, Kaylee, and thank you and welcome. I'm so glad you're all here with me today, and I really mean that. I say that every Wednesday that we have a webinar, and sometimes people, oh yeah, well that's just what she said. No, I really do mean it. It means that you're interested in what's going on, and it means that you're thriving and you're being successful because you want more information about what's happening in your body, or better ways to do things, or easier, faster, whatever, just learning different information. So, always finding out information is a good practice to have, no matter what the topic of concern is. So, we're going to talk today about what things should look like in body functions, because we always talk about things, what shouldn't be there. But very rarely does anybody say, this is what this should look like. So we are going to talk about that. But of course, with the current events in the world, I have to bring up COVID yet again. And Kaylee and I were talking earlier, and we're like, oh, we're still talking about COVID. Yes, unfortunately, we still are talking about COVID. And the big news now, of course, is there's this new Omicron variant that has come out. And yes, it is in our country. And I was thinking about talking about this the other day, and I thought, well, it hasn't been officially documented in our country, but it's in our country. What came out this morning, it is in our country, so it's official now. So I can say that and have that be correct information. But obviously, it travels so fast and so easy. So this new variant, the Omicron, what is different about it is that it has a much longer spike. So when you see the picture of the COVID virus on the news or in a magazine or online or whatever, when it first came out, it was this ball, and it had these spikes with these red triangles on the end of it. And that depicted what the original COVID virus looked like. And then very subtly, I found this very interesting because I didn't hear anybody say anything about it. But one night I was watching the news, and all of a sudden they showed the picture that, that they show every time of the COVID virus, but the spikes had turned blue, and they were talking about the Delta variant and how this was now the dominant variant of the virus. And I thought, and now it's got the blue spikes on it. So when they show a picture of it and it's different, it's kind of a subliminal message to us to say, look, something's changed. And they talked all about it, but they didn't say, did you notice our picture is different? And in fact, it was. So I thought, what is this Omicron? What does it look like? So I took a look at what that looks like. And now they're depicting it as the ball, and they still have the spikes with the red and blue triangles at the end of it. But now they have some spikes coming off this ball that are like 3 or 4 times as long as those ones with the red and blue spikes on it. And these spikes they're depicting as gold in color. And I thought, well, that's ironic. Why make it gold? I don't know. Maybe it looks yellowish. I don't know. But anyway, so that's what the Omicron looks like. And these longer spikes, and they have more of a rounder head instead of that triangular head on them. And so that makes it easier for the virus to slip into your body cells, so it can replicate inside your body. Anyway, the whole process of the virus transmission and all that is just very fascinating. These long gold spikes, because they're longer, they have more surface area, and that's what attaches to your cells. And these spikes are much stickier than the original and the Delta variant spikes were. So if you get the virus into your respiratory system, or, it's just as easily to get it up through the urethra or the rectum. People forget about that. Remember, we want to avoid the public restroom kind of thing, because there's a lot of virus in public restrooms, because it's excreted. A virus could still be living that could be excreted out of your body, or it's just a way of transmission, because the cells that are lining your respiratory system, they're also those same cells in your urethra and in your rectum and bowel. They're not as thickly populated, but there's still plenty of them there. So you want to be very careful with any of your open areas like your eyes, your nose, your mouth, your urethra or your rectal opening. Ears, not so much, because, you know, they have a waxy substance that protects them. And so it's a little bit of a different mechanism to try to get something in through your ears. I suppose they can. If you have an opening on your skin, got a little cut on my finger here the other day from a Christmas wreath. And I thought, oh, I got to keep that bandage, even though it was a little tiny cut, because it's an open area in my skin. The virus can get in there pretty quickly and pretty easily. So thinking about all of those kind of things, we still need to be super, super cautious about things. We don't want to let our guards down. Now, I know many of you have been vaccinated. Some of you have not been vaccinated. The reason why I hear most people with neurological injury are not getting vaccinated as well, it hasn't been tested enough in people with neurological injury. And we don't have really an official word about that, but we have had over 300 million people vaccinated in the United States. So it's been well trialed. As with any kind of medication or even food, anything that you ingest into your body, there's a certain amount of risk that goes with that. But still, you know, some people are being cautious about the vaccinations, and some people are, most people are being very cautious either way with the mask wearing and hand washing, social distancing, and all that sort of thing. So we need to really, really be careful with those kind of things, because nobody knows what this new variant is going to be, the Omicron. Is it going to make people more sick? Is it not going to be so bad? You know, we don't know that yet. So we're still finding out, because it's all new and it's all evolving. So nobody knows. So, the one thing that I have noticed is that during this whole COVID thing, and I have been hyper vigilant about protecting myself, and my mother, who's 94, has been hyper vigilant about protecting herself, because, you know, I think she would be worried that she would disappoint me if she wasn't. But anyway, for whatever reason, we're all protecting ourselves. And we've all known people that have had the COVID and have had very bad illnesses with the COVID and have been hospitalized, and people that have died. But it seems to me like those people, at least in my world, have been people of somebody who knew somebody. There weren't a lot of people in my social circles that had gotten it. There were some people who got it, but maybe they had milder cases. They were hospitalized. Maybe they got out of the hospital, but I didn't personally know people. I knew of people that had died, but not people that I really personally knew that died. And I was thinking about it the other day, because actually my mom ended up with the COVID. Long story, but anyway, she got it fully vaccinated, and I had the booster. I was with her maskless, and I'm like, oh my gosh, got tested. I was completely negative. We called the doctor, said, you know, she's got this positive test, and well, she qualifies for the monoclonal antibodies. And those are antibodies that have been taken from people who've had the virus but have survived. And so they created these antibodies from the blood plasma of those people, and they multiply them so that there's a good supply of that now. And so the doctor said she should go have one of these. She'll, you know, and they say you'll feel better in 24, 48 hours. She didn't feel really bad. She never had a fever. She didn't have the typical symptoms. And as it turned out, it took her about 72 hours. And she was showing remarkable signs of being better, just like you can almost watch her minute by minute of her symptoms going away. So it was kind of fabulous to watch. I was watching over the computer because I didn't want to get it. And so, you know, that's a difficult time when you want to take care of your loved one, but you can't. And so anyway, now she's completely better and she's negative. And so that's been a really good thing. So I highly recommend that. if you get those. I recommended it before. Since the beginning of all this, I've told all my nursing friends, now, if I get this, you be sure and tell my doctor I want the monoclonals right away. So I got to see that played out in real life. And that was kind of an exciting thing, because I like looking at that kind of stuff, but even better that my mom got all better. So good for her. So anyway, so here we are with this. So, but it seems like, I used to know people out in the world that had COVID and maybe even died from the COVID, but now I'm seeing a lot more people in my social circle that are getting these milder cases. They're all vaccinated. They're getting these milder cases. There's one lady that I know who's I will say about 50, 55 range, something like that. She's got the COVID. She didn't qualify for the monoclonals because she didn't have a lot of symptoms, but she is getting better. She had a real mild case, and she's been hyper vigilant because she lives with her elderly parents. So, they were really being very cautious. And so somehow she got it. So I think that it seems to me like that's the way it is now, that it's kind of coming. Now, this is just Linda talking. This is not CDC kind of things. But my observation as a nurse researcher is that it seems to be coming in more people that have been vaccinated now, these breakthrough cases. I'm not saying that you've been vaccinated, oh, you're going to get it. I'm not. Get vaccinated. I'm a vaxxer, so I'm in that camp, and I admit to that. But it just seems to me like it's, that the world of COVID is constantly changing. And this is what I see in my world. You'll draw your own conclusions about what it's like in your world. So stay strong, keep following all the rules. It's certainly better than it was, but we're still going to have some time with this, fussing around with this COVID thing. There's a whole lot of new treatments that are coming out with for the COVID as well, that are in the pipelines. Again, they're all, new treatments. So some people are going to be like, well, I don't know about that, but you have to draw your own conclusions, but talk to your healthcare professional immediately if you get diagnosed, or if you have any symptoms of the COVID at all, the fever or the cough or loss of taste and smell, all those. You can have one, you can have several. Don't think, oh gosh, I feel real achy today. I think I'm getting a cold. The symptoms of cold, flu, and COVID are very close together. So if you're at all feeling unwell, be sure and talk to your doctor. Maybe you'll qualify for the monoclonals. You can have that if you're vaccinated or if you're not. I think in every state now, it changes day by day, the rules and with the monoclonals in the different states. So, talk to your doctor, because that's the person who will know what you should do next. So don't delay. Don't let it get a good grip on you. Get treatment right away and stay cautious. That's the lesson learned here. So let's think about what things should look like in your body. So I was writing about this last month about what your urine should look like. And of course, we all know if there's blood in your urine, or if it's a strange color, but what should it look like? So urine should be kind of this very pale yellow color, almost the color of straw even. It can even be clear, because that can mean you're very well hydrated. It could also mean, though, that you might have some kidney filtration problems. But if you know what your urine looks like on a daily basis, then you'll know what your standard is. So be sure and have a look at your urine. People who catheterize, that collect their urine in a bag, they can look at that bag and they can, because they are discarding it. So they see it, they know what it is. But if you use the toilet, have a look at it in the toilet. The toilet water will dilute the color a little bit, because, you're mixing it with a bowl of water. So it will get diluted a bit, but know what your color is. And it will not be, it's like your blood pressure. It won't look the same every single time, but it will look a little bit darker in the morning, because you haven't probably taken in fluid during the night, whereas during the day you're drinking and moving about. So it gets a little bit lighter as the day goes on. If your urine is a real dark yellow or orangish color, maybe you need to take some fluid, maybe you have an infection, maybe you have some blood in your urine. So know what your color of your urine should look like. Now, there are some tests and there are some medications that will change the color of your urine. So when people go through some catastrophic kind of illness, no matter what it is, friends, people that, I interact with in clinics or whatever. And so I'll say to them, what is the one thing that you would want people to know? Because people talk, oh, how are you doing? But people like to be helpful. So I always ask people, what's the one thing you would like to know, would like for people to know? And I know a lot of women with breast cancer because a lot of women have breast cancer. And so I'll say to them, and it kind of gets off the, the morbidity of the topic a bit, because people like to be able to contribute to other people. Say, what is the one thing? If you could tell somebody one thing, what would it be? Because if I meet somebody else who has breast cancer, what's the one thing I should tell them? And by and large, it is when they get tested and they have the dye put in, they're told that the urine will turn blue, but it won't turn blue and pass through their whole system until they get home, and they'll go to the bathroom and they'll look and their urine's blue and they'll get all upset, so people need to know that urine's going to turn blue. Well, when you're told this, you're getting your test or you're just been given this diagnosis and you're told this, you got a lot of information coming at you. And so now if I meet somebody who's diagnosed, don't forget that when you get the dye test, that your urine's going to turn blue. And so they'll always come back kind of laughing about it. And they'll say, Linda, I was told, I got home, I went to the bathroom. Oh my gosh, my urine is blue. Oh, wait a minute. Linda told me my urine would be blue and it's okay. Now they told me, but because it was this one separate interaction, it kind of stood out more or something. So anyway, just different things like that. I always think so if anybody has anything really huge going on in their life, what's the one thing you would like people to know? People who've had open heart surgery, the standard instructions are in about 6 to 8 weeks, you'll be, pretty much back to normal and you'll be going up and down the steps. And I have yet to meet anybody who's had open heart surgery that was kind of back to normal in 6 to 8 weeks, more like 6 to 8 months till they're feeling like themselves. And so that's something I try to tell people. And I remember this one elderly gentleman, he was like, oh no, it's going to be 6 to 8 weeks. My doctor told me. I'm like, okay, but just know back in the back of your brain, it might take a little bit longer. It might be 6 to 8 months. And I saw him quite some time later and he's like, Linda, it was 6 months. And I'm like, okay. Now, fortunately, most people don't have open heart surgery anymore because they do so much with the cardiac cath now that a lot of our cardiothoracic surgeons are retraining into other surgical opportunities because the number of open heart surgeries are so low. Well, isn't that terrific? So that's good. So anyway, I diverge off of what urine should look like, but that's what urine should basically look like. Sometimes people who catheterize will see sediment in their urine, and that can be just a product of being still. It can be a product of bone demineralization. It can be a product of infection. Some people just have sediment in their urine all the time, and other people don't. When you're moving around, your urine is more shaken in your bladder, whereas if you're sitting and you're still, it kind of has the opportunity to formulate into more sediment. If you void into the toilet, you probably won't see sediment in your urine because, again, it's mixed in that bowl, and generally the toilet bowl is white, sediment is white, so people don't usually see that. Just so you know, if you typically have that, you've talked to your doctor about it, and they've gotten the okie dokie on the sediment in your urine, you don't need to worry about it unless it's like a hugely large different amount or it's changed colors or something like that. Okay, so what should your stool look like? Now, stool is really variable. It should be pleasantly brown. And by that, I mean not too light in color and not too dark in color. If you haven't had a chance to look at the Bristol stool scale, This was developed in Bristol, England, and it is like the greatest thing to a rehab nurse that there ever was. So I love it. It's Bristol, Bristol, and that's the name of the hospital where it was developed. You can go online. They've got pictures of the scale, and it's just very clear. It helps us all to communicate about stool because people are always worried about what their stool should look like. So it should be kind of middle of the road brown. It should be formed. If you look at the Bristol stool scale, it should be at level between level 4 and 5, somewhere in there, which is a form stool. Sometimes 4 has a little more lumpy, 5 is a little more smoother, and so that's normal. And then it goes up to the level 1 is constipation, and so that's lumps either coming out as hard little lumps or stool that's just clumps of lumps. So really hard stool is what it comes down to. And that is a sign of constipation. Most definitely that's constipated stool. But remember, if you have neurological injury and you have neurological bowel, some people look at their stool and say, oh, I'm constipated, I need to take medication for constipation. Well, in fact, maybe you do. But the reason why your stool looks like that is because in neurogenic bowel, the stool passes so slowly that a lot of the water is taken out. So it gets hard and it gets constipated. But it's not an artifact of constipation. It's an artifact of the fact that you have a neurogenic bowel that's moving slowly. So you have to treat yourself for neurogenic bowel. Now, a lot of people, I had one mother, and oh my gosh, she was just delightful. And she would call me, Linda, I'm at the naturopathic shop and I'm looking for something for constipation. And I'm like, the problem is neurogenic bowel. And it took us a long time to get there, but we finally got there. But she was just, no, I see it, it's constipated. Yes, but if you treat the right problem, you're going to have the right success. So if you treat constipation, you're still going to have neurogenic bowel and it's still going to be constipated. If you treat the neurogenic bowel, you might eliminate you more than likely will eliminate the constipation problem. So that has to do with that. The other end of the Bristol stool scale is diarrhea. And this is really important to look at this. These are drawings, so there's not like really gross and disgusting to look at this, but they're just cartoon drawings. And so diarrhea is solid liquid. It's just solid liquid. The level above that is some liquid stool with some chunks in there. That's not really total diarrhea. Most people, if their stool comes out too fast or uncontrollably and it's loose, they call that diarrhea, which is not. And the treatments are a little bit different. So once we know what everybody's talking about, it makes it much easier. Now, there's people that have added to the chart with pictures of different kinds of candy bars. So like a baby Ruth is more of a constipated stool, and hot cocoa liquid is more like diarrhea. Some people have done it with soup so that people can kind of get a better idea. So talking about stool is really hard because, people, it's such a private moment and people really don't want to go into their healthcare professional and talk about that. So again, look at your stool so you can see it's not going to be the same at every single bowel movement. Sometimes it's going to be a little harder. Sometimes it's going to be a little softer. A lot goes into the production of stool. So it depends on what you eat. It depends on your mood. And, everybody knows, a lot of people have had the experience where they get nervous or anxious and they get a little bit of diarrhea or their stool's coming very fast. But also, anything that elevates your mood can do the same thing too. There was a guy that wrote in one time about his problems with, he was paraplegic and his problems with stool function. I wish I had saved this article because it was just so to the point. And so he had his fiance and they were in the car and he was driving, and they were going to meet her parents. And guess what happened? Now, this was a happy time. He was happy about meeting, loving his fiance, happy about meeting her parents. Such a wonderful time in life. Oh, everything's going great. And he's in the car to meet the parents. And what happens? He has a bowel incontinency. And apparently it must have been a humdinger. And he had to get in the back and change his clothes. And it was just this horrible mess. And so all they could do was laugh about it. And, you know, what a good attitude that is. But anyway, it was just it was a wonderful story because, you know, stool passes at the most inopportune time sometimes. And it usually has to do with our emotional state. Not that you can keep yourself stoic and solid. You know, our bodies just are reacting. Everything interacts in our body, and that just happens. So what should my skin look like? Well, you know, it should have, it took me a while to think about this because it should have, it should be clear without blemishes. Now, you can see I have little rosacea. You know, people have little rashes or whatnot. Get to know your body, look at your body. It should be clear. It should have a kind of a soft feel to it. And I say a soft feel to it because your skin has this tiny layer of moisture on it at all times. It's kind of almost like a mucous membrane, but not as wet as in your mouth or in your nose or in your eyes, or in your rectum or in your urethra. But it kind of should feel soft because there's a little bit of moisture on top of your skin all the time. And so that's what it should look like. Consistent pigmentation throughout. Sometimes people have a little different coloring on different parts of their body. And so, you know, get to know what your skin looks like. Look at where you have a mole. Look at and see if you have any kind of pigmentation changes over bony prominences, or if you've scraped. I got a rug burn on my elbow the other day. I was cleaning something on the floor and I got a rug burn on my elbow. So know what your skin looks like at any point in time so you can see where there is a change. Make a record. Just about everybody has their own personal cell phone, so you can take pictures. And then, you know, they're on your cell phone, they're confidential. And so you can see what did my skin look like last week? Hey, I see a spot there. Was that spot there last week? I'm not quite sure. So you can go back and you can refer and see if that change has really been made or how that is. If you have any change in pigment over bony prominence or any place in your body, that could be a developing pressure area. So you need to stay off of that. Pressure areas are like icebergs. There's a little bit that you see a redness, or if you're darkly pigmented, you might see more of a purpley, or sometimes people describe it as an ashy spot on their skin. But what is underneath is much more. So it's like an iceberg. You have a little bit of redness on the top, and then you have this damage to the tissue inside your body. So really, pressure injuries generally start where the bone presses up against the inside of the skin. By the time you see it on the surface of the skin, this in here has already done a lot of damage. So you really need to stay off that area. You need to do your pressure releases. Even if you have pressure dispersing equipment on your bed and in your seating, you still need to do all of those kind of things, because that is what keeps you from having troubles with pressure injury. So keep all of those things in mind. Doing that pressure releases, that really provides a lot of exercise to your body that you don't even know you're getting. It helps you with breathing better. It helps, not only does it help reduce your pressure risk, but it helps exercise your body if you're doing push-ups, if you're tilting from side to side, if you're rolling in bed. It really helps move your body. It helps your bowels move better. It helps shake up the urine in your bladder to keep it from getting better. Like I mentioned earlier, when you're sitting, that urine is just sitting in your bladder. But if you're moving around, it shakes up that urine. So it just helps so many things. So, you do something for one thing and it helps 100 other parts of your body because everything works together. So speaking of skin, somebody wrote in about, they had a question about severe sweating. And sometimes people who have spinal cord injury because of that autonomic nervous system, it gets getting the wrong message and people have this severe sweating. And so somebody wrote it, is there something I can do about this? And I've known people who've had to change their sheets maybe 4 times at night because sweating is so bad. And then, they get dehydrated and there's all kinds of difficulty with that. So if you have this really severe sweating, you can take anticholinergics for that. There is one that most people take is propanthyline. I'll spell it's PROPANTHELINE. That's the most common one, anticholinergic taken for the severe sweating with spinal cord injury. Now, a lot of people with spinal cord injury don't sweat below the level of the injury. That's the typical way it goes. But as in all of healthcare, for whatever rule there is, there's a rule that negates that. And this hyper sweating can occur in some individuals. So if you have that, you should talk to your healthcare professional about trying that. Now, if it's not too bad, if you have some sweating, but it's not too bad, you can try using some lotions or antiperspirants. If you're sweating on your arm, you can roll the antiperspirant on your arm here. You want to be careful about how much you use that, because if you close off all of your sweating, you can get overheated. So, talk to your healthcare professional to get the right treatment that's for you. But that's generally like the hierarchy of things. You usually try the simplest things, and then I guess you try the simplest things for the least invasive problem, and then you move up the ladder to the more severe things. There are some surgeries that can be done for sweating, and those are not too often done because this is really out of the box kind of thing. People don't usually it's controlled just great with this medicine. However, it is an anticholinergic, which can give you dry mouth. So some people don't like that sensation, but some people will take that over all the sweating. Some people, you can regulate the dose, so maybe that's not so bad, or you can use Biotine or different products to help moisten your mouth. Something else that anticholinergics are typically used with neurogenic bladder. So if you have a neurogenic bladder and you're taking medication for that, and then you start taking more medication for your sweating, you can have a problem. So you really need to coordinate that all together. Now, what's really great is if you can get a twofer. So if you have one medication that helps your bladder, but also controls your sweating just with one pill instead of multiple, trying multiple different things, that's always great too, if you can limit what you're doing. Which brings me to the point of one of the other things I wrote about this month was to recheck your medications. And you always want to do that at least annually or every time a medication's added on. Now, we all go to the healthcare provider's office. They give us a medication. We take the medication home and we start taking it because this is what was prescribed to us. But what we really need to do is we need to check with the healthcare provider. Now, most have everything on computer. So when they add a medication, they get an alert immediately if this will affect some other medication that you're taking, or they might be alerted that you shouldn't eat certain foods, or you shouldn't combine this with some other kind of thing that you might be applying to, or breathing, inhaling, or whatever you might be doing. It's important that you let your healthcare provider know every single medication that you're taking. If it is over the counter, if it is complementary medication, something that you got at the healthcare, at the nutrition store, if it is a lotion that you're rubbing yourself, if it is recreational medications, every single thing that you swallow, that you inhale, that you rub on your body, that you insert into your body, that you inject into your body. Make sure they know every single thing, because the pharmacist also has all of that on their computer. And they can put in, I want to try some CBD oil. And so they can put that in your record that you're doing that. Oh, wait a minute, that conflicts with this other medication that you're taking, or that will make this other medication work much more, give you more effect, or it will make this other medication not work as well. So you need to make sure that everything has been tested. You can go to medication checkers online and check it out yourself. I do advise that you do have a professional, your healthcare provider or your pharmacist, work with you on that. But there are a lot of medication checkers that you can put in different combinations of medications, foods, and, to see what those conflicts are. Now, there's a lot of herbal supplements that people take that affect their blood clotting, and even foods that people might eat. So some blood thinners can't be taken. You can't eat green leafy vegetables with them. Read that package insert when you get a new prescription. You can skip over the chemical compounds, the real scientific-y kind of stuff, but read the warnings, read the risks, read the contraindications, read the side effects. I am always shocked when I talk to groups of people who are older that are taking cholesterol medication, how many people take that in the morning when the instructions are to take it at night, because at night is when you make most of your cholesterol, when you're sleeping. So that is bedtime medication, but most people take it in the morning because they take the pills and they get them all over with, and they haven't read the package instructions. So that's very important to do as well. So those are the things about that. Another question that we have in here is, will exercise for hands and arms help with spasms? And there's a very clear answer to that. It's yes. So that's important to know. Now, why does that help? And it is because your body craves movement. And within every muscle, there's its own relay system where muscles will want to contract. Muscles are grouped in pairs. So there's muscles that push and there's muscles that pull towards the body. So the muscles that pull towards your body are always a little bit stronger than the pushing. That's why it's easier to pull things than to push things. It takes more energy to push things. But that's why, because it's a little bit stronger to go towards your body. If you look at people who have contractures, you'll see that their arm is pulled towards the center of the body. If they have contractures of their legs, the legs are pulled up towards the center of the body. So when you have spasms, it's these muscles are not getting the input from the brain because the spinal cord injury or the neurological problem, be it stroke, Parkinson's disease, MS, Guillain-Barré, the message might not be getting to a particular muscle, that it's not getting the feedback that it's trying to seek. So you can provide that externally by doing your exercises and ranging every single part of your body to make sure that you are getting input to those muscles. So the muscles are receiving input if I am moving it, or if I'm moving my finger on my own, the muscle's still getting the input. Now, if I'm moving it on my own, my finger on my own, that message is coming from my brain, and to stop, it's coming from my brain. If I'm moving it, it's providing input to the muscle. And then this way, the nerve pathway is going up to the place where the blockage is, that message isn't getting through. So if you can think about, I'm moving my finger while somebody's moving your finger, hopefully the message from your brain, move my finger, and the message from your finger, I'm moving, will come together and make some kind of connection. That is the goal. So all of exercise with any kind of paralysis or spasms from any kind of source of injury, that's the thought behind that. So exercise for your hands and arms do help with spasms. The other thing that it does is, if you keep going, it can fatigue the muscles enough that the spasms get reduced. Now, sometimes the spasms are just so great that you're exercising, and it's important to keep to exercise to keep those joints supple and to provide that input to the muscles. But sometimes there will also need to be something else, either some medication or something else to help with, to control the spasms, because sometimes they can become overwhelming. And the more you spasm, the more chance you have of getting contractions or contractures or other kinds of problems because of the spasms. And they can be so intense that some people, you know, have to wear a safety belt on their wheelchair because they get thrown out of the chair just because their spasms are so intense. So exercise does help that. If you can range, that's the beginning. If you have other kinds of equipment that can exercise your body, then by all means, that gets you even more input into reducing those spasms through exercise. So some people use functional electrical stimulation to reduce their spasms, you know, and you just go up the ladder. Some people use Botox that reduces their spasms, but you still need to provide that physical input to your body a couple of times a day to do range every single move, every single part of your body, so that every single muscle gets some input. It's very important to do that. But yes, exercise will help with spasms. Here's a related question is, my fingers seem to be very stiff and still much weakness and pain. Is there any kind of hand therapy that will help? My hands are turning inward, so I'm thinking like this, and my wrists are weakening. So that is starting to get those contractures. So doing those range of motion, getting all the joints, there's a lot of joints in the fingers, so getting all of that moving, going up to the wrist, don't forget the thumb over here, doing your elbows. I don't know if you can see my elbow, doing your shoulder. When you're sitting up, you can move your shoulder back. If you do your exercises in bed, the bed kind of stops you from moving your shoulder back unless you're on your side. Same with your hips. So I did see this little thing advertised for Christmas, and I think it was maybe for golfers or something, but it was this neat little hand exerciser. It cost $30, and it was done with rubber bands. So there was like a cuff around the wrist and then a rubber band from each finger attached so that you stretched out your fingers with this little device, which I thought was rather cool. Now, you know, to me, I'm looking at for alternatives to expensive medical equipment. If you can get medical equipment that will do range of motions to your hands, they do have those. They're very expensive. They're very hard to get. But if you can get that kind of equipment, well, and machine does it great, doesn't matter. If you use a local stimulator that makes your hand expand and contract, that's another possibility. That is a little bit easier to get than these mobility devices that move all the joints all at once. But yeah, some hand therapy would help. If you have movement and you can use like some silly putty, that helps with closing of your hands, but then you still have to do that stretching to pull your hand back open. You can very gently stretch all the fingers at one time. You don't want to stretch too hard. Therapists can help guide you in how much you should be stretching, because sometimes if the hand's starting to turn, there might already be some muscle contractures in there that you could eliminate still soon enough, because you do still have that movement in there. So I was thinking about this little thing that I saw with the rubber bands, and I was thinking, you know, I would like to try that. I was looking for a rubber band, but I would like to try that to see if you had a rubber band and put it like on the finger this way, and you'd probably on this tip, it's going to come flying off. But if you put it here, you wouldn't get the pull of the tip of the finger. But if you put that rubber band and pulled it so that your finger was, and you could put it down on this joint, you know, that might be something that you could try. But again, talk to a therapist so that you're sure that you're doing the right thing for you. But there are all kinds of things to do to get your hands and arms. With the stiffness and the weakness, but you have some movement, so you want to capitalize on that strengthen those muscles to be able to get more movement. Now, I've talked about this many times, but just in case you haven't heard about it, there is a study that's being conducted at the University of Washington in Seattle. And I'm real hot on this because it's just like ingenious. So, you know, as I said, people will try electrical stimulation and it'll do their hand or maybe their wrist. They put it on the muscles near the nerves where they want stimulation to happen. And so that works out and that's good. But out at the University of Washington in Seattle, I want to say the doctor's name is, I want to say incognito, but I'm sure I have to look it up again. But you can go to you can look up University of Washington tetraplegic hand exercises, and it goes to their site where they have this information. And so they've taken the electrical stim, just a handheld device, not an expensive device, just a handheld device. They put 2 electrodes right over the spine at the top of the neck and then one just above. And what they found out was people who had tetraplegia, so people who have paralysis of their arms, and they stimulated actually over on the skin or the spine, no surgery. And they thought, well, let's see what this does to hand function. And they were astounded because people got so much hand function so fast. They needed some therapy to learn how to harness that, how to use that. And they thought, you know, it would take, I don't know, so many sessions or whatever. No, it was like a couple, 3 or 4. And people were able to use their hands and do all kinds of things. Now, not real fine motor things, but enough to feed themselves, maybe to use a pen, turn a key in a lock. I mean, just lots of things. And then when they turned it off, when therapy time was over, that even without the stimulator on, they found that the carryover was still there for a while. So even without, after being stimulated, stimulations removed, they're still able to do that for a little while afterwards. Their protocol is on there. So you can get their protocol, take it to your therapist and ask your healthcare provider, would this help me? I mean, they're being really, oh, we've got it here in the chat room, how you can get that. They're being real free with that. It's not like you have to pay them or you have to go there. They're just like giving this away. It's wonderful. And it's like a really big deal because who would have thought, well, let's move the electrodes and wow, look at all the things we can do. So that's pretty exciting stuff. And I think that plays into a lot of what they're doing with the experiments with the spinal cord stimulators implanted. It all works hand in glove, but this is kind of like a precursor to that. So, you know, if you're interested in that, it's really, it's a game changer for a lot of people. Let's put it that way. Is there any devices that can help rebuild muscle in the lower extremities? Now, that's a weighted question because if you have upper motor neuron injury, those are the people who have spasms. They have too much tone. They're hyperreflexic. Those are injuries in the cervical cord or in the thoracic cord. So in the C or the T's. So electrical stimulation does beautiful with building muscles, and it takes a short time, a few months, and your leg muscles are all built up. It does a lot of good for your body. It's a lot of good that comes out of that. Now, people who have the lower motor neuron injuries, they have hyporeflexive nerves and muscles. So they don't take stimulation very well, if at all. And so the FES does not work. You can do passive, but it's really hard to build up the muscles in those lower level injuries, the L's and the S's, lumbar and sacral. But there are things that you can do because at the very end of the spine is where the spinal nerves come out at the tail, the horse's tail, they call it. It's called the cauda equina in healthcare, but it just looks like a tail of a horse. All these nerves come out. Once the nerves come out of the spinal cord, they are peripheral nerves. Those can be stimulated. So they are working on implants where implants are put on those peripheral nerves that can help stimulate. So that's an opportunity for that kind of injury, but it has to be lower level for building muscle and walking and that sort of thing. They can also put this stimulators on the peripheral nerves to the bowel and bladder for bowel and bladder function. And those systems are, I don't know if they're in market yet. They were ready to go to market, and then the COVID hit, and everything slowed down and or stopped. And so I'm not sure where that is in the process right now. But if you look at the FES Center at the University of Cleveland, they were very close to going to market before the COVID. And so it will be shortly. And so there's these implants that you can get for bowel and bladder function that work with like a magnet or a button that you press on your abdomen. And for males, they can even be harnessed for sexual function. Now they're making their implants modular so that you can start out with an implant for bowel and bladder, and later on you can add on lower leg motor function. The problem with ambulating in humans is not so much the possibility of doing it. People can ambulate even with high level of injuries in a partial weight supported walker where their legs are rhythmically patterned to walk, walk, walk. They go through this. They have a machine that makes the legs move on a treadmill, and you walk, walk, walk. Now, and people will do that even after the therapy is over. Their legs will start moving on their own. And people who have lower level injuries that use braces are reciprocal gait orthotics. So when they move one leg, it causes the other to move, and they can walk using crutches. So people can be educated in their nerves and muscles to walk using assisted devices. They've got those exoskeletons. It can happen. The hard part, in my opinion, is the balance and coordination. So because it's not under your brain's control, and finding your equilibrium of being upright and finding your balance of holding your body upright is the challenge, because you don't have that sensory feedback of where your body is in space. So it's very difficult. That is a piece of this puzzle that I think, my personal opinion is, I think with these spinal implants, I think a lot of that sensory is going to be restored, because we've discovered as motor function is restored, sensory function is restored even quicker. So I think that it's all starting to come together. In my mind, it's all starting to come together. So I think we're going to see a lot of things going on with that. Now, there's somebody who had written in, I can't remember if we addressed this or not, but there's always a lot of questions about colonoscopy. And so people don't like to do the bowel program, and they think, well, I have that colostomy, excuse me, two different procedures. Okay, so a colostomy, and it'll be so much easier. Well, think about this, because for some people it is easier, for some people it's not easier. If we kind of, in healthcare, we kind of say that save the colostomy as a last resort, because we want the body to work naturally. And we want to be able to have treatments ready if there's a problem. And so the colostomy is kind of a high level treatment for the problem. So we want people to do bowel programs, but there's some people that have such problems with it, they like to do the colostomy, either their physical problems or their mental problem. It's difficult mentally for some people to think about doing a bowel program. So there's a lot of reasons for having it, and the valid reasons for having it. But remember, if you have a spinal cord injury, especially if it's a higher level injury, the person that wrote in had a C5-6 complete injury. Well, C4 is right where the breathing mechanism is. So if it's always at the cervical level, even at the thoracic level, even sometimes at the lumbar and sacral level, it's harder to get off the ventilator. Now, people do all the time, but it's for the higher the level, the much harder it is to get off that ventilator. So you want to think about complications. and breathing is a huge one. So you get the colostomy, but then you have to have a ventilator, so you have to really talk to several healthcare professionals about a surgical procedure, no matter what it is. And, talk about ventilation and talk about the respiratory things. Now, if you go to your surgeon, they're keying in on the surgery. They're like, oh yeah, we can get you off that. I've done other patients, we've got them off that. Talk to your surgeon, talk to your own healthcare professional, because they know your whole case best. And you might also want to have a pulmonary consult before you have that surgery to make sure that you're going to be okay ventilatory wise after that. Now, so a benefit of having the colostomy electively is you get to pick out where you want to have the colostomy. So some people like to have it closer to, the opening is going to be on the abdomen. Some people like to have it closer to the end of the bowel so they have time to absorb the nutrients out of their food. Some people will elect to have it closer to where the large intestine has transitioned from the small intestine. And then the stool is much looser. Now, sometimes people think, oh, well, now I can't do the bowel program myself. I'll have this bag. Some people will be able to change the bag where they can't do the bowel program. But most of the time, if they don't have the hand function to do the bowel program, even with assistive devices and that sort of things. So some people will have an attendant change the bag. Talk to that attendant. Some attendants won't change a bag, but they'll do a bowel program. So, sometimes it's a wife or spouse or whatever, they'd rather do the bowel program than have that colostomy because they're having this raw stool that they're having to deal with instead of form stool. So people have different opinions. So you have to discuss this with everybody who's taking care of you. Also remember that if you have a colostomy, the bag can fall off. And what are you going to do in that case? Can you replace it yourself? Sometimes the stoma can become irritated, and can you take care of that yourself? Can you empty the colostomy bag yourself, or will you need somebody to help you? Sometimes stool comes out like we were talking about, even during happy occasions. Sometimes stool comes out more forceful than other times. And so think about if you have an explosive diarrhea attack and that colostomy bag goes sailing and you've got a mess, will you be able to deal with all those kinds of things? So there are people who have colostomies and they love them, and that's great. I've also seen people who've gone in for elective colostomy surgery and they've died because their body couldn't take the surgery. Not that it was the colostomy surgery, it was just that their body just was not up to the whole surgical process. So infections happen, really talk through. I feel like I sound negative about colostomies, and I am not at all. I think you should do, what is best for you, but I like for people to know all the things about it. Some people just think, oh, all I have to do is change that bag and then, it's all over, it's done. Life is never that simple. So I try to give people the ins and outs of all situations so that when you go to your healthcare professional, you are armed with questions that you thought of and questions that you didn't think of, but maybe you need an answer to, or maybe you need to explore more. So there's all kinds of different things to every single situation. So with that, we come to the end of our hour, and I hope that this has been informative today. I hope you had a happy Thanksgiving, and I'll talk to you closer to Christmas time, and also a happy Hanukkah, Kwanzaa, whatever you celebrate, or if you don't celebrate any, a happy December. And stay safe. Stay away from that COVID if you can, because it's out there. So have a good month.